Welcome back. As you know, in our last class, we were discussing factors that impact on wound healing, and the system suddenly decided that we were done and cut us off. So we are going to cover the content that we missed in this little additional segment on wound healing. I'm not totally positive where the system cut us off, so if I duplicate a couple of slides, I apologize and feel free to just fast forward. So in this section, we're going to talk about the impact of systemic factors with a particular focus on nutrition and the impact of those factors on wound healing with implications for us as wound care nurses. So first, we know you have to have adequate blood flow and adequate oxygenation of the tissues if you're going to get normal wound healing. Blood flow is essential because blood flow, the bloodstream carries oxygen, carries nutrients to the repair site, picks up waste products and takes them away. We know that if you have a very poorly perfused wound bed, that wound will not heal until perfusion is corrected. We see this in patients who have ischemic wounds involving the lower extremities. Until we can improve blood flow, we don't get any healing. What about oxygen itself? Well, oxygen obviously is essential to every phase of wound healing. Within the inflammatory phase, you have to have oxygen to support bacterial killing. White blood cells essentially load their guns with oxygen. So if I'm a white blood cell and I take aim at this bacteria, but my gun is empty, I cannot kill the bacteria. So I have to have oxygen to be able to effectively phagocytize that organism. You have to have oxygen in the inflammatory phase to establish a clean wound bed, to establish bacterial control. You have to have oxygen in the proliferative phase because oxygen fuels the repair process. It provides the cells the energy needed to synthesize collagen, to make new epithelial cells, to create crosslinks. Every phase of wound healing dependent on adequate levels of oxygen, which is in turn dependent on adequate perfusion. What's the critical level? Studies to date indicate that throughout the repair process, you have to have oxygen levels of at least 30 to 40 millimeters of mercury. Based on that, you'll sometimes see with patients who have lower extremity wounds, sometimes they will do TCPO2 levels to determine, okay, is there enough oxygen to support the wound repair process? Do we need to send this patient for hyperbaric oxygen? That kind of thing. We'll come back to that and talk about it more, but I just want you to realize there's a critical baseline that you must meet in terms of oxygenation. Here's an unanswered question. Does more oxygen improve the rate of healing? If we gave all of our patients supplemental oxygen, would it actually help them heal their wounds faster and better? We don't know. At this point, the implications for us as clinicians is to make sure that the wound is adequately perfused and that there are no barriers to oxygenation. Specific barriers that we commonly encounter other than adequate perfusion is the impact of edema. When you have very edematous tissues, you literally have a lake of fluid in between the capillary delivering the oxygen and the wound bed. And those oxygen molecules have to essentially swim to get to the wound bed. You've seen this in patients with venous ulcers, but you'll also see it in patients with trunk wounds if the tissue is very edematous. So if we have a wound in an area compromised by edema, we have to get the edema under control if we're going to optimize wound healing. What do we know about cigarette smoking? We know that cigarette smoking compromises oxygen delivery. It actually replaces oxygen with carbon monoxide. So if you want that wound to heal, you've got to talk to that patient about the negative impact of smoking. You've got to see if you can come up with a short-term contract. Might not be able to get them to agree never to smoke again, but can you get them to agree to use a nicotine patch, possibly meds, support to significantly reduce or eliminate smoking until we get the wound healed, many patients will sign up for that once they know exactly how smoking impacts the repair process. So talk to your patients. Leave the decision-making in their hands, but make sure that they're making informed decisions. What about nutritional status? We've already said fibroblasts are the only cell in the body that can make new connective tissue proteins, but fibroblasts cannot make connective tissue proteins out of thin air. You have to provide the essential nutrients. You have to provide them with amino acids, the building blocks for new cells. You have to have, again, enough energy to fuel the repair process. Nutrition is so critical that we're actually going to use the last half of this class to talk about nutrition in detail. What about steroids? What about other medications? So the categories of medications that are known to interfere most significantly with repair include high-dose steroids, high-dose non-steroidal anti-inflammatory drugs, and chemotherapeutic drugs. So let's start at the bottom. Let's start at chemotherapeutic drugs. Those drugs are cytotoxic and they act systemically. So if I have a patient getting chemotherapy, can I get that wound to heal? And the answer is almost always no. So if I have a patient on chemotherapy, I'm going to tell him or her right up front, at this point, our goal is not to get the wound to heal. We're not going to be able to get the wound to heal until you're through with your chemo. At this point, my focus is on preventing infection and preventing deterioration, if at all possible. What about high-dose NSAIDs? Most of the time, we don't have patients on such high-dose NSAIDs, but if we do, and we have a very poorly responsive wound, we want to talk to the prescribing provider about tapering down the NSAID dose, maybe using alternative therapies. What about steroids? Steroids is probably the category of drug about which we have the most information and the most data. The information to date, the studies to date, suggest that the impact of steroids on wound healing is very much dose dependent. And the critical level seems to be around 30 milligrams a day for 30 days or longer. So very low dose, probably minimal effect. Short term, probably minimal effect. So a patient who's on a Medrol dose pack, you're probably not going to see any significant impact. But a patient who's taking 30 milligrams of prednisone a day because of rheumatoid arthritis or some other inflammatory condition is at very high risk for delayed healing because steroids block the migration of white blood cells into the wound bed, and we know that white blood cells are critical to the initial phase of wound healing, the inflammatory phase, responsible for wound cleanup. But also remember that macrophages release the growth factors that attract fibroblasts to begin the proliferative phase. So if we shut down the inflammatory phase, we pretty much shut down the whole process. Is there anything you can do about it? We have limited data that indicates that topical vitamin A can partially counteract the negative effect of steroids without adversely affecting the therapeutic benefits of steroids. How? Well, vitamin A has the opposite effect of white blood cell migration. It attracts white blood cells, attracts macrophages. Come on down, come on in, we need your help. So if you want to try to counteract the effects of steroids, think about topical vitamin A. It will do no good until you get the wound cleaned up, but remember you can usually do that mechanically by mechanical debridement, surgical debridement, enzymatic debridement. You can usually go a long way toward controlling bacterial loads with antimicrobial dressings and antibiotics. So if you have a clean wound bed, non-granulating wound, think about using topical vitamin A. How would you do it? You would get a vitamin A capsule, poke holes in the end of it, squeeze it into the wound bed, follow it by whatever dressing, very high tech. So how did they learn about this? Well, they actually did a study way back where they took human volunteers and they created wounds on each shoulder. And one wound was treated with topical vitamin A and the other wound was not. and the wounds with topical vitamin A healed a lot faster. Now, this was only patients on steroids. Vitamin A has no impact on patients who are not on steroids. So just think about it. True that we have very limited data, but also true that the only real adverse effect of topical vitamin A would occur in a patient who's in advanced liver failure. So for the vast majority of our patients, it's extremely safe, it's low cost. So the cost-benefit ratio says, give it a 2-week trial unless there's a specific contraindication. Okay, so that's steroids, NSAIDs, chemotherapy. What about aging? Yes, aging has a negative impact on wound healing. We know that little kids heal faster than adults, and we know that middle-aged adults heal faster than elderly. We also know that as we age, more of our cells become senescent. And remember, senescent cells don't participate. They're like people who are retired in place. They're not helping. So senescent cells don't reproduce, and they don't really contribute. What can we do about it? Well, right now, we don't have a magic bullet that will convert a senescent cell into an actively participating cell. Here's what we do know. When we have a reduced set of functional cells, it's even more important that we manage that wound absolutely perfectly. So if I have an elderly patient, I'm going to work really hard to correct etiologic factors. I'm going to look at all systemic factors that can impact, and I'm going to optimize them to the extent possible. I'm going to watch that wound like a hawk. I'm going to titrate my topical therapy as the wound changes. But here's the other thing. I have to be very patient. If that wound is progressing slowly but surely, I should just stay the course. I shouldn't keep changing, because I should recognize that this patient is not going to heal at the same rate as a much younger patient. And we're going to see many more of these patients. We already have a lot of patients in their 90s. We're going to have patients who are 100 plus. What about obesity? Yes, a major risk factor for failure to heal. You have an obese patient who has abdominal surgery, very high risk for dehiscence. What can you do? Well, you can recognize that fact. You can recognize that fat is poorly perfused and heals much more slowly. You can also recognize that mechanical stress is much greater on an incision when the patient's morbidly obese. Should we be using abdominal binders prophylactically to provide incisional support? Yes, we probably should. The fact that we don't have great data doesn't mean that we shouldn't use the principles in our common sense. So support that incision. Also remember that most of our morbidly obese patients are diabetic, which trips right into the importance of tight glycemic control. And that's our next point. We know that hyperglycemia adversely affects every phase of wound healing. It interferes with white blood cell function. Specifically, once your blood glucose levels rise above 180, your white blood cells essentially become paralyzed. High glucose levels have the same effect on white blood cells as overeating has on us. So think of you after Thanksgiving dinner. What do you want to do? Lay on the couch, maybe manage the remote, maybe not even that. Okay, if you take a white blood cell and it's functioning in a hyperglycemic environment, it's sedated, it's sluggish, it's almost drunk. So it's like, I see you, bacteria, I'm going to get you later. Right now I have to rest. We tell patients all the time, if you're diabetic, you're higher risk for infection. Specifically, you're higher risk when your glucose levels are out of control. So we've absolutely got to keep your glucose levels lower than 180. But we now have a lot of data, a lot of it based on cardiovascular surgery patients, that shows that the optimal range for glucose levels is 110 to 140, and that the A1C should be less than 7. Again, talk to your patient about a short-term contract. We don't have to get them on board for the rest of their lives. Yes, we'd like to, but right now our focus is wound healing, which can be an object lesson for them. So you want to explain to them the impact of glucose levels on wound healing. And you want to see, are they willing to commit to a very tight control program until we can get this wound healed? Many times I found that patients can commit to things short term that they can't commit to for the rest of their life. So if I talk to you about the rest of your life, that's overwhelming. But if I talk to you about the next 3, 4, 6 weeks till we get this wound to heal, that's different. Look at what pregnant women do to get a healthy baby. They give up all kinds of things. Patients will too. So just make sure they know, be sure you're willing to work with them and that you convey that to them. Okay, so we're going to kind of summarize some things. Let's talk about things we can do to promote incisional healing, okay, acute wound healing. So what can we do preoperatively? Well, they're going to reduce steroids if possible. They're going to eliminate aspirin-based products and any product that could adversely affect clotting, because we know how important clotting is, not only to hemostasis, but also to healing. Do everything possible to optimize nutrition. Studies have shown that even 10 to 14 days of adequate protein intake preoperatively goes a long way toward improving their ability to heal postoperatively. And we want to reduce anxiety as much as possible, because anxiety causes sympathetic stimulation, which causes vasoconstriction, which impairs wound healing. Postoperatively, pain control. Again, keep that sympathetic response under control. Keep your vessels open and able to deliver adequate amounts of nutrients and oxygen. Keep the patient warm for the same reason. Do everything you can to optimize perfusion. That might be IV fluids, okay? That might be blood pressure control. What about oxygen? Well, if you have any concerns about that patient's ability to oxygenate postoperatively, if they are showing low O2 sats, should we intervene? Absolutely. We want to keep oxygen levels at least in the normal range. What about incisional care? We don't have as many studies on incisional care, but we go back to our principles. Initially, if you have a stapled or sutured incision, you have little gaps between the sutures or the staples that can permit bacterial invasion. So early post-op, you typically want a sterile, occlusive dressing that seals the wound, keeps bacteria out. Many agencies now use an occlusive antimicrobial dressing. So they have an antimicrobial island dressing that goes right over the incision, and then they have an occlusive border that seals the incision and protects it until epithelial resurfacing can occur. We've already talked about the importance of incisional support, especially in your patient who's obese or who is coughing a lot. What about chronic wounds? Well, you're going to hear this a lot. You've heard it once or twice already. You're going to hear it nonstop over the next few lectures, and that is, when you're managing a chronic wound, you always start by determining and correcting etiologic factors, whatever they are. Now, if it's a dehisced incision, you have to think about, well, what contributed to dehiscence? Was it wound infection? We've got to treat the wound infection. Was it malnutrition? Okay, we've got to address those nutritional deficiencies. Was the patient on high-dose steroids? Maybe we need to think about topical vitamin A. We want to provide systemic support for healing, so again, control edema, look at smoking cessation, make sure patients are getting adequate nutrients, make sure glucose levels are tightly controlled, all of those things. We want to identify and eliminate any infection, because infection will stop healing in its tracks and cause marked deterioration in the wound, so we'll spend a lot of time talking about that when we get to wound management. And we want to make sure that when we're selecting our dressings, that we're selecting products that will establish and maintain a clean, moist surface. Spend a lot of time on that in the next few classes. Okay, so in our last few minutes, we're going to focus specifically on the importance of nutritional support for wound healing, and specifically our role as nurses. So which nutrients are essential to repair? You already know this. You know you have to have adequate protein levels, because what's collagen made out of? what are connective tissue proteins made out of? In other words, what's all that new tissue made out of? Protein. So you have to provide enough protein to maintain bodily function, to maintain normal cell turnover, and to provide for synthesis of new connective tissue proteins. Studies to date indicate that the amino acids glutamine and L-arginine are particularly important. Now, those are amino acids that in a healthy person ingesting a normal diet, those are easily produced in adequate amounts. But in patients who are compromised, they frequently are not producing enough glutamine and enough L-arginine. So there are some supplements out there. And if you have reason to suspect a glutamine L-arginine deficiency, for example, you know your patient's getting adequate nutrients, you know the wound is well perfused, you've got a clean wound bed, and yet the wound is non-granulating, then you might stop and think, hey, there's enough protein, but is this patient producing enough glutamine, enough L-arginine? Might they benefit from a 2-week supplementation trial to see if that's the problem? So just remember that patients who have open wounds are at risk for glutamine and L-arginine deficiency, and there are supplements for just that reason. You have to have adequate calories. If you don't take in enough calories to fuel the body's ongoing cellular metabolism, then what happens? The body's like, I've got to get fuel from somewhere, so I'm going to break down protein. I'll break down the protein in the diet first, and then if I'm not getting enough that way, I'll break down the soft tissue in the body. So you have to provide adequate calories to spare the protein and to fuel the repair process. You also want to think about vitamins and minerals, because the more we learn about the processes involved in wound healing, the more we realize that micronutrients matter just as much as macronutrients. That when you're synthesizing collagen, not only do you have to have amino acids, but you also have to have zinc and vitamin C and B vitamins and copper and iron. So in other words, they need total nutritional support. So the implications for us are very clear. We need to assess all patients with open wounds for nutritional status, and we need to look at what are they getting in. So in looking at nutritional status, maybe you look well nourished at baseline. Maybe your weight is within normal limits, BMI is within normal limits, but all you're doing is taking sips of clear liquids. And in the way of support, all you're getting is IV fluids. Okay, you're not going to be able to heal your wound until we correct the problems with your intake. So when I look at you and assess you, I've got to assess not only your status at baseline, but also how much are you taking in. If I have any concerns, you're cachectic at baseline, you have unplanned weight loss at the time you're admitted, you're morbidly obese, or if I have concerns about your intake, I should initiate a nutritional consult. I need somebody on my team to help manage you who understands nutrition in depth. And finally, you've got to realize that there is a significant impact of tissue trauma and injury on appetite and nutrition. So when we have patients who are ill or injured, they're producing more pro-inflammatory cytokines. Those little proteins that control the repair process. And remember, pro-inflammatory cytokines attract white blood cells to the wound bed, but they have systemic effects as well. And the systemic effect is, among other things, anorexia. So you know how many patients say to you, I'm just not hungry? I tried, I feel like if I eat one more bite, I'll just throw up. And we're like, but you haven't had anything. Profound anorexia as a result of the pro-inflammatory cytokines produced in response to injury or illness. I think that there has to be implications for research there. If we could just package small amounts of pro-inflammatory cytokines, and give them to all of us who are trying to limit what we eat and just get just a little bit of anorexia, just kill our appetites a little bit, don't you think? Somebody should be working on that. Pro-inflammatory cytokines also contribute to muscle wasting. They impact on your ability to utilize, absorb protein byproducts like nitrogen. So the very fact that your patient's sick or injured compromises their ability to utilize the nutrients provided and also compromises their ability to take in adequate nutrients orally. Okay, so what's my responsibility as a wound care nurse? Well, I should be able to do a baseline nutritional assessment, and I should be able to do baseline interventions and certainly to support the team in doing higher level interventions. So when you look at a nutritional assessment, there are 4 critical elements. First, I should look at anthropometrics, like your weight and what's happened to your weight in the past few weeks and months. I want to look at my labs, but I don't want to attach too much importance to my labs. We'll talk about why. I've got to look at you clinically. So what does your skin look like? What does your hair look like? What do your mucous membranes look like? Do I see generalized edema? What's happening with your wound? All of those clinical parameters tell us a lot about nutritional status. And I've got to determine how much you're taking in. There are some great tools on the market. The 2 that are most commonly referenced are the Mini Nutritional Assessment Form and the Malnutrition Universal Screening Tool, so MNA and MUST. You may very well be using those forms in your agency. If not, you might want to go online and download them and just see, hey, could this improve our ability to quickly and accurately perform a nutritional assessment? Okay, let's talk about anthropometric data. So I want to get your weight. I want to get your body mass index, your BMI. Here's the categories, and the ones in bold are the ones that are red flags. So if your patient comes in and they're underweight at baseline, so their BMI is less than 18.5, that's a red flag. They're probably going to need a nutritional assessment and intervention. Now, 18.5 to 24.9, normal. No red flag there. 25 to 29.9, overweight, but not in the category of obese, so not really a red flag there. But if your BMI is over 30, now you rate as obese, and as it goes up, you're moving toward morbid obesity. So if you have a low or high BMI, red flags means that patient may need further assessment and intervention. Equally important, possibly more important, is what's been happening. Has this patient experienced unplanned weight loss? Unplanned weight loss means that the body is breaking down its own tissues, even though I'm not trying. I'm not consciously restricting my intake. I haven't consciously ramped up my activity. So what's going on that my body is breaking down tissue? What I know is that if this patient's losing weight and the body's breaking down existing tissue, they're not going to be able to heal their wound till I get that process turned around. So critical levels, if they've lost more than 10% of their usual weight in the last 6 months and it was unintentional. So what if my normal weight is 150, but now I weigh 135, okay? So I've lost 15 pounds, 10% of my weight, over the last few months, and I wasn't trying. I just can't eat as much, or whatever. Or short term, if I've lost more than 5% in the past 30 days. So you want to ask your patient, have you been losing weight? What's your usual weight? Okay. I remember having a retired nurse who came into clinic very, very concerned about this dehisced wound she had. First thing I noticed when she walked down the hall is that she looked very thin and she looked very dry. So she's asking me all these questions about the wound. And I'm like, let me first ask you some questions and then we'll get to the wound. So we are going to weigh you today. Okay, so we weighed her today. She's like, well, I know what I weighed at home. I weighed 110. Okay, she was about 5'8". Okay, we weighed her on our scales, she weighed 112. We're like, okay, 110 to 112. What's your usual weight? Well, I'll usually weigh about 125, but I'm not worried about that. We're worried about that. And this is why. Everything that you're doing to take care of your wound is exactly right. Your wound bed is clean, but it's not granulating, and it's not granulating because you're losing weight. You're not getting in enough nutrients even to maintain your body's status quo. No way you're going to be able to heal this wound until we turn that around. So you want to talk to your patients what's going on weight-wise. What about labs? Well, in the past, we've paid a lot of attention to labs. We've paid attention to albumin, prealbumin. Some people have used transferrin. Those are all visceral protein levels. And they are affected by protein intake, protein absorption, by nutritional status. But unfortunately, they're also affected by many other things. So trauma causes a drop in your visceral protein levels. Infection causes a drop in your visceral protein levels. Dehydration can make them look a little bit better than they really are. So affected by many other things, not just nutritional status. So that brings you to the last point under lab data. You cannot use your lab data as standalone indicators of nutritional status. Having said that, when you look at your labs, the one that is most reflective of current nutritional status is prealbumin. Albumin is not nearly as helpful because it has a very long half-life. It changes very slowly. Prealbumin has a much shorter half-life, so it changes much more quickly. So it's a much more accurate indicator of what's going on in the body. But remember, a low prealbumin might be indicative of compromised nutrition, but might be indicative of unrecognized infection, trauma, that kind of thing. What about clinical observation? Clinical observation is very important. It is a direct window into the patient's nutritional status. So what do you see? Do you see soft tissue and muscle wasting? That's the body breaking down its own protein stores to try to just keep the body moving, keep cells functioning. Do you see dry, easily pluckable hair? Well, if you don't have enough protein, you're not producing hair normally. Your hair's not growing normally. And it affects the hair follicle so that it's easy to pluck hair out. Do you see dry, flaky skin? Do you see cracks in the mucous membranes? Remember, skin, mucous membranes, hair, all protein dependent. So you'll see those changes. And when we have a patient with an open wound, it's like a window into the body. So if I have a wound that's clean but not granulating, why? Inadequate protein intake is a common reason for failure to granulate. Not the only reason, but a common reason. The next thing I want to look at is current nutrient intake. Now, if I have a patient in an inpatient setting, acute care, LTAC, long-term care, the dietary department will work with us, and they'll post a calorie count sheet, and they'll get the nurses to write in how much the patient ate at every meal, and then they'll come back, they'll collect the sheets, they'll calculate intake, they'll tell us what the daily intake is, they'll compare it to the patient's needs, and they'll tell us what the deficit is. It's wonderful. What if I'm an outpatient? What if I'm in home care? I may or may not have a nutritional support person on my team. If I don't have a nutritional support person on my team, here's what I can do. One of two things. I can either walk the patient and their caregiver through a 24-hour recall. Tell me what you ate for breakfast yesterday. Tell me what you ate for snacks in the morning. Tell me what you ate for lunch, snacks in the afternoon, dinner, and evening. Tell me what you drank all day long. And even though it's not as accurate as an objective recording, it's pretty accurate. Or you can ask them to keep a record of everything that the person eats and drinks and bring it back at their next clinic visit or at your next home health visit. Then it's going to be up to you to go online and find a calorie counter or to work with a nutritional support person to do an analysis to determine, okay, what's their caloric intake, what was their protein intake. Critical to know what they're getting in. Otherwise, you don't know what the deficits are, you don't know what you're trying to correct, except in very general terms. Okay, so now let's move to intervention. Let's say, back up just one step. Let's say I have a patient who comes in, they look a little bit on the thin side and dry, and they tell me, yes, they've been losing weight. I notice little cracks in their mucous membranes, their wound is non-healing. So I'm pretty concerned based on my clinical assessment on the anthropometrics. Let's say my lab data is non-specific, I'm not going to hang my hat on that. I definitely want to find out what they're getting in. And if I have access to a nutritional support person, I would have already enlisted their help. Now we're going to move to the intervention phase. Again, do I have someone either in a consultant role or on staff who can help me, who can do a more in-depth assessment and help me come up with a very appropriate management plan? If so, I definitely want to enlist them. If not, I'm going to do the best I can with the information I have. You can, as a nurse, do a pretty accurate calculation of the patient's nutrient needs. So there's been a lot of work done on this, and so there are some quick formulas that are designed to determine in a patient with a wound, how much protein do they need every day? How many calories do they need every day? How much fluid do they need every day? So you can take your calculator, and in less than 5 minutes, you can come up with a very specific nutritional prescription. This is what you need for wound healing. So the first thing you're going to do is you're going to take the patient's weight in pounds, and you're going to convert it to weight in kilograms, because all the formulas are kilogram based. So you go back to, okay, let's see, there's 2.2 pounds in a kilogram. So I'm going to enter your weight divided by 2.2 equals, and that gives me your weight in kilograms. Once I have your weight in kilograms, I can multiply it either by 30 or 35 to determine what are your caloric needs. How many calories do you need to get in to support wound healing? I'm going to take your weight in kilograms and I'm going to multiply it either by 1.25 or 1.5 to determine the number of grams of protein you need every day to support wound healing. And I'm going to take your weight in kilograms and multiply it by 30 to determine the approximate amount of fluid you need. Now, for most adults, it's about 2 liters a day. And remember, if you have a morbidly obese patient, you don't want to give them 4 liters of fluid just because they're morbidly obese. So fluid, that's definitely a ballpark. So now I'm going to give you an example. Let's say my patient weighed 154. So I do 154 divided by 2.2 gives me 70 kilograms. I multiply that by 30. It gives me 2,100 calories a day. I multiply it by 35. It says 2,450. So that tells me my patient needs a minimum of 2,100 calories a day to promote healing. I multiply 70 by 1.25 or by 1.5, and I get 87.5 to 105. So they need a minimum of 2,100 calories and a minimum of 87.5 grams of protein. Now what? Now I'm going to compare their current intake to their nutrient needs. So let's say my patient needs 2,100 calories and essentially 88 grams of protein. But what they're getting in is about 1,400 calories and about 60 grams of protein. So what's my deficit? You can calculate, okay, I need this many additional calories, I need this many grams of protein. And then you can work with your patient. What I have found is that I get a very different response based on my approach. So approach number 1, which I used for years. You know, you really need to eat more. We're never going to get this wound to heal if you don't eat more. Patient's like, I know, but I just don't have any appetite, and I take a few bites and I'm just so full. I hear you, but if you don't eat more, your wound is not going to heal. We've got to get enough protein and calories in you to get your wound to heal. I know, I'm really trying. I'll keep trying. Okay, have we made any progress? No. I'm telling them something, they're telling me something. Approach number 2. The approach I used with my retired nurse. I said, Barbara, based on your weight and our goal to get this wound to heal, you need at least 1,800 calories and at least 70 grams of protein in every day. And based on what you've told me, you're getting in less than 1,000 calories and maybe 40 grams of protein. So let's look at how we can fix that. We can take several approaches. Let's look at what you eat for breakfast. So you told me that typically you eat dry toast and you eat some yogurt and you have some herbal tea. Okay, yogurt is great. Let's stick with that. You could add some powdered milk to your yogurt to give even more protein. You could modify your dry toast. You could do cheese toast and you would be adding calories and protein. Or could you add 1 poached egg and that would give you calories and protein. Let's look at mid-morning and adding calories and protein. Could you eat a half of a peanut butter sandwich? Could you drink a nutritional supplement? Once she realized exactly what the deficit was, I think for her, the deficit was 400 to 600 calories, and the deficit was about 30 grams of protein. Once she realized what the deficit was, she's like, I'll figure it out. I'll figure out how to get in that many more calories and that much more protein. I'll figure it out. I'll go to the health food store. I'll look at labels. I can figure this out. I've had other patients, if I handed them a list of high protein foods and gave them a target, they're like, okay. And then they would come back and they'd say, okay, here's what I found at the health food store. You might want to pass this on. Very different if you give people very specific targets, the information they need, a very specific target, and the tools to reach those targets. So you can modify their existing intake, you can put them on targeted supplements, whatever, and it should be their choice. You could, go with commercial supplements. There's many commercial supplements, but of course they're more expensive. So some of the just protein drinks are cheaper than the nutritional supplements. So whatever works for your patient. What about tube feedings? Well, you want to think twice before you go to tube feedings. If you can possibly get the nutrients in orally, that's what you want to do. Tube feedings, we do not have good data showing that use of enteral feedings significantly improves rates of wound healing. Maybe it does, but we don't have the data yet. And anytime we put down a tube, we add a whole list of potential complications, aspiration, as well as others. So don't be too quick to suggest tube feedings. Yes, sometimes it's what we have to do because we literally cannot get the food in orally, the nutrients in orally. We want to exhaust oral before we go to enteral, and parenteral is always a last resort because it's so expensive and so many complications. Now, the next couple of slides, this is reference information only. We're not going to hold you responsible for this. This is what your dietitian knows backwards and forwards. Like, wound dressings, they know these formulas. They can look at your patient and their history and they can say, not that one, this one. Basically, 3 types of formulas. You have your protein intact, lactose-free. It's like your meal in a can, essentially. So that's what we use a lot, your Ensure type supplements. Then we have peptide-based. Those are the pre-digested formulas. So they're helpful for patients with short gut syndrome. So the proteins are broken down into peptides. And the carbohydrates are broken down into specific components. Everything's broken down so that it's ready to be absorbed. more expensive, don't taste as good, are frequently hypertonic, so they might require dilution. I wouldn't want to be the one making the decision about that. I would want the registered dietitian helping me with that. And then you have disease specific. So there are formulas out there for people with chronic obstructive lung disease. There are formulas for people who are diabetic. There's formulas for people with renal failure. Again, your dietitian knows these inside and out. So next bullet point, you need the dietitian in helping you to select and initiate enteral feedings. That's their role. They do it so well, you really want to tap into their expertise. So they're going to recommend a formula based on on the patient's needs and their comorbidities. General rules are start low, typically about 30 milliliters an hour, and gradually increase the rate based on patient tolerance. Dilution is not usually required because today's formulas are already isotonic. They have water added, so they're no longer hypertonic. You don't have to dilute them down unless there's a specific indication to do so. So generally, start low, go slow, dilution not required. We do want to pay attention and reinforce complication prevention. So yes, we want to be part of the team in preventing aspiration, which means another negative to enteral feedings. We have to keep the head of the bed elevated at least 30 degrees. During feedings, if we have to put the head down, we need to stop the feeding. If we have to elevate the head of the bed, we need to gauge the knees. We want to monitor their tolerance. We don't want them vomiting. Sometimes you have to end up using a jejunostomy tube instead of a gastrostomy tube so you get past the pylorus. Sometimes we end up using meds to facilitate gastric emptying. Everything that we can do to prevent aspiration. The other big complication is diarrhea. This is why a lot of nurses hate tube feedings, because they link tube feedings to diarrhea. I remember one intensive care unit where they would call us up and they'd say, okay, I have the tube in, I have the feeding ready to go, but I'm not starting it until you get up here and help me get on one of those perianal pouches because I know what's coming next. Interestingly, many times diarrhea in a tube-fed patient is not because of the tube feeding per se. Many times it's because there's an unrecognized impaction and now we have stool leaking around the unrecognized impaction. Many times it's because we're giving their meds, we're giving them liquid versions, so elixirs, which have a lot of sorbitol, which is a laxative agent. Sometimes it's because the patients had very compromised intake for a number of weeks and the little villi and the small bowel are flat. And so when we start feeding them, their absorptive surface has gone from this to this and everything shoots past. What do nurses want to do? They want to turn it off. But what you want to do is go back to start low, go slow. Because if we continue to stimulate the villi, what will happen? They'll be like, wait a minute, what was that? Did I see food? And they'll gradually get back up. So it could be a number of things causing the diarrhea. It could be unrecognized C. diff. So most of the time it's not the tube feeding per se, the tube feeding just fuels the process. So you want to do a careful assessment to determine, well, what's causing the diarrhea in this patient. And then you can determine how to proceed. So some things that frequently make a difference: reduce the rate, make sure that the formula you're using has soluble fiber so it tends to absorb moisture and keep the stool soft or formed. Very slowly increase the rate. Make sure they don't have C. diff. If they don't have C. diff, then you can use antidiarrheal medications. So bottom line, when we look at nutrition and its role in wound healing, absolutely critical to identify and manage any nutritional deficiencies. The wound will not heal without the essential building blocks. If you're unable to provide the essential nutrients, you need to revise your goals for wound management because you know that wound is not going to heal without the essential building blocks. Now, let's talk about vitamins and minerals. We're almost done, but we have to talk about vitamins and minerals, also known as micronutrients. I wish I could give you some very clear direction that was evidence-based. But we have very limited data to guide our advice. Let me give you an example. Most centers recommend a multivitamin mineral supplement to patients with open wounds. I've done that many times. But when you go to the literature, there's practically no evidence to support that because the studies haven't been done. So should we continue doing that? Yes, probably, because we know that many times our patients are not getting everything they need. But can you say at this point that there's a strong evidence base? No, you can say that there's generally clinical consensus. What about vitamin C? For many years, we gave additional vitamin C to patients with open wounds based on the fact that vitamin C is essential to collagen synthesis and that you lose a lot of vitamin C in wound fluid. But on the other side, most foods and fluids contain vitamin C. All of your supplements contain vitamin C. All of your enteral feedings contain vitamin C. So do you really need additional vitamin C? Again, probably not. We're not sure. If you want to recommend additional vitamin C, the good thing is that it's water soluble, so you're not going to get into toxicity, but most of the time it's not needed. What about zinc? That's another thing that everyone got put on for a period of time, and they got left on it for a long period of time based on studies that showed that zinc was essential to collagen synthesis, and if you didn't have enough zinc, you couldn't heal your wound. But we now have additional data that says if your zinc levels are too high, it causes gastric irritation, which compromises nutrient intake, and it also compromises copper absorption. And copper is also important to wound healing. So here are the current guidelines. They may change, so stay tuned. But current guidelines do not provide supplemental zinc unless the patient is known or thought to be zinc deficient. Well, how would you know? You would only know if you did a zinc level, and there's not even good agreement as to what constitutes normal. But what would make you highly suspicious that this patient is zinc deficient and that they might require short-term supplementation? Any patient who's been on a very deficient diet, who has had very deficient intake for a number of months. Okay, well, what foods contain zinc? Well, primarily your protein-based foods, your meats, peanut butter, beans, that kind of thing. So if a patient's been eating very little, just picking at things, primarily eating carbohydrates for several months, would you have reason to believe that they might be zinc deficient? Yes. In that case, what should you do? Short-term, 2-week supplementation at 220 milligrams a day. Okay, we are through with wound healing. We will move ahead to wound assessment in our next class and then into wound management. So take a break. Thank you very much.